We have one more topic to cover before our live panel discussion. The first two topics have been an excellent example of organ preservation, the theme of our conference today. Dr. Mariana Arvanitakis with Erasmus University Hospital in Brussels will share her expertise and experience about cannulation techniques and interventions to prevent post-ERCP pancreatitis. And the lecture.
Hello, dear friends and colleagues. My name is Mariana Arvanitakis from the Erasmus University Hospital in Brussels, Belgium. I'm very happy to be part of this winter webinar on organ-preserving interventional endoscopy and the pancreas session. And the focus of my talk is cannulation techniques and interventions to prevent post-ERCP acute pancreatitis. So this is the agenda of my talk. What are we going to talk about? First of all, the important steps to take before introducing the scope, some elementary but crucial aspects of anatomy, the papilla and the biliary and pancreatic ducts, standard and advanced techniques of cannulation in ERCP, including precut, and the very important issue of prevention of post-ERCP acute pancreatitis. So before introducing the scope of the patient, the first question is, does this patient really need ERCP? We know that post-ERCP acute pancreatitis is a devastating complication, and the best way to avoid it is not to do the procedure. So indication is really the clue here, correct indication. We will review all imaging procedures, the CT, the MRI, before putting the scope in, and we will examine lab tests, coagulation tests, and the need or not for antibiotic prophylaxis. We will discuss the treatment plan with your team, and before starting, we will assure that there are optimal conditions regarding sedation. And if there's any problem, it's best to stop the procedure and consider general anesthesia with your anesthesiologist. During the procedure, control of duodenal peristalsis is important to avoid over-insufflating CO2 and destabilization your position. And we'll see that position is probably the most crucial thing to obtain successful biliary cannulation. When you put down the duodenoscope, you will put some pressure on the greater curvature and find yourself in front of the pylorus. So this is when you're in front of the pylorus, to go through it, you will have to put the tip of the big wheel upwards, and by doing this, you'll lose the image of the pyloric lumen and have what we say the sunset image. And by pushing a bit, you'll find yourself inside of the bulb. Then to get into the second portion of the duodenum, you will turn your body to the right, and by pushing a bit, and then by retrieving back the scope by torquing it in a clockwise direction, you will find yourself in this very stable, typical position, which is not always easy to obtain in some types of anatomy, and this will be shown in the video I will show you at the end of the session. So once you're in front of the papilla and the D2, I remember my mentor Jacques Devier that always told me, let's do some papillology. And it's very important to examine the papilla and find the landmarks, the longitudinal fold that will lead to the papilla, the orifice, and you know that the upper part towards 11 o'clock is the biliary orifice, and the low one towards 5 o'clock is the pancreatic orifice. Then you have the horizontal fold and the infundibulum, and these are very important also when you're going to do your sphincterotomy. So what happens behind this orifice? You see the convention of the two ducts, the pancreatic and the biliary duct, and these will join in the ampulla, which is kind of small common hallway. And you see that every papilla will be different, and this is very important to examine it, because behind things will also change. You will have a very short common channel, sometimes two separate orifices, a standard common channel, and a very long common channel, as you can see here. So you will decide what device you will use. You have catheters, standard or steerable, sphincterotomes that will give you this extra bend to go towards the biliary direction. And wires, depending on what technique you use, long versus short. And usually what we will use is an hydrophilic with a bended tip. So getting the right angle is important. If you try with a standard catheter with the papilla facing in front of you, you will probably go into the pancreatic duct. As you see the angulation of the ducts here. If you want to get to the biliary duct, you have to push a bit the scope to be a bit underneath the papilla and turn the left wheel to the right to have this right to left direction and have most of the chances to get into the CBD. Another way of obtaining this angulation is to use a sphincter tone, because with the bended sphincter tone, you'll have this extra angulation to go towards the 11 o'clock direction. So, as we said, papilla in the center or slightly above. So you are positioned downstream the papilla. Small weak smile to the right, clockwise, to have the right towards left direction. You use a catheter or sphincter tone. A sphincter will give you that extra bend. Approach the orifice with small movements and touch it as least as possible. With your device, you will have to obtain what we call insinuation. So putting the tip of the device in the orifice and feeling that you're somewhere. You shouldn't fight, of course, with the papilla, and you will use mostly a guide wire, or we'll see that some small amounts of contrast or both are useful for obtaining deep cannulation. And the next important step is getting through the angles, because the way is not straight in the bile duct. There are a lot of angles. You have this S shape. So once you get initially in the first part of the CBD with a small wheel clockwise to the right, you shouldn't push. You will just accentuate the angle. What you will do is you will turn the wheel anti-clockwise to the left and bring back a bit the scope to have a more horizontal axis, and you will then tackle the second part of the CBD. And finally, by bringing back your small wheel to the right and pushing it back the scope to be to your initial position, you will get through the last portion of the S shape of the CBD. So guide wire contrast, what do we know? We have a lot of data on this, and this meta-analysis already had showed us that the guide wire assisted cannulation technique will increase the primary cannulation rate and reduce the risk for post-ERCP acute pancreatitis. So it would appear to be the most appropriate first-line cannulation technique, but you see with a high number to treat at 31. What is in the recommendations? Well, the recommendation as well chose the guide wire assisted technique for primary biliary cannulation because it will reduce the risk for post-ERCP pancreatitis, and will suggest the use of hydrophilic tipped guide wire for the cannulation. But what do we really do? Well, we will start by cannulation, guide wire cannulation, but if this fails or it's difficult, we might use a little bit of contrast to define the anatomy of the pancreatobiliary junction. It's important to use this contrast injection as gently as possible, with the least amount, and of course expertise in both guide wire use and contrast use are crucial. That's why assistants should also be very well trained for this. There was also a recent randomized controlled trial that put this question to a test. So it's consecutive patients undergoing ERCP with a native papilla. They compared the guide wire versus this mixed technique, and primary outcome was post-ERCP acute pancreatitis. Secondary outcome was time to successful biliary cannulation. And we see there's a high number of patients. And finally, this mixed technique, which really represents what we do in real life, seem to decrease post-ERCP acute pancreatitis and promote faster cannulation time. So a guide wire is indicated, but you can still use some contrast wisely if you need. What happens when the going gets tough? So this is when it's difficult, meaning that you have more than 5 contacts with the papilla, more than 5 minutes spending attempting to cannulate, or more than 1 unintended pancreatic duct cannulation or pacification. In this case, you will need some patience and you will need advanced techniques. What do we have in our disposition? We have the pancreatic guidewire assisted cannulation. We have needle knife techniques and transpancreatic biliary sphincterotomy. So what to do? You have to take a deep breath. You can also change the instrument, use a smaller caliber, ultra-tapered sphincterotome, change the position. We work in supine position with the patient with general anesthesia, but we usually, when things get difficult, we can try to turn the patient to the left lateral. And by changing the rotation, sometimes you can cannulate. We'll use advanced cannulation techniques, pancreatic guidewire assisted technique or pre-cut techniques in transpancreatic sphincterotomy. But also you can also stop and reschedule, call a more experienced colleague, or refer to a tertiary hospital, always depending on the indication. So pancreatic guidewire assisted biliary cannulation, it's the technique of choice if you have already a guidewire in the pancreas. The guidewire in the pancreas will kind of straighten the anatomy and facilitate the access next to this guidewire with a sphincterotome in the CBD, but it's recommended to finish the procedure with a pancreatic stent if the guidewire is still in place. What about a pre-cut technique? This is needle knife sphincterotomy. It can be done by fistulotomy when it's done above the papillary orifice, or papillotomy, either freehand, either over a stent. And finally, transpancreatic sphincterotomy, which consists of making a sphincterotomy through the pancreatic orifice, but towards the biliary orifice to cut through the septum, and then try again, cannulation. This is can be very useful in expert hands, but these techniques do require experience, and a badly done pre-cut may jeopardize future ERCP attempts. So this should be taken into consideration if the operator is non-experienced in this technique. What about prevention of acute pancreatitis? This has been taken into consideration drastically in the quality indicators, which are metrics that will measure the impact on clinical relevant outcomes and can be measured. And they were post-ERCP acute pancreatitis was both taken in consideration in the European and the American quality indications you can see here. And also in the American publication, we have the very important issue of indication, the correct indication, because performing ERCP without a clear indication is a mistake and should be performed when there's a clear therapeutic aim, and this is a priority indicator. And this is the list of accepted indications: cholangitis, stone extraction, malignant biliary obstruction for tissue acquisition and stenting, treatment of biliary leaks, patient with painful chronic pancreatitis and strictures or stones, patients with recurrent acute pancreatitis duct changes for pancreatic duct drainage, and the investigation and stenting of MPD strictures. And we can see that some previously accepted indications had been taken out of this list. This is the indeterminate abdominal pain and the infamous SOD type 3, doing routine ERCP and biliary sphincterotomy before cholecystectomy in all patients, and routine biliary drainage with unresectable pancreatic malignancy when the surgery can be scheduled in less than 2 weeks and there's no cholangitis. So specific for preventing acute pancreatitis after ERCP. First of all, we define the risk. We know that not all patients have the same risk. We have determined definite and likely risk factors, patient and procedure related. These risk factors can also have additional value, which means that you have a young patient with a suspected sphincter body dysfunction, female sex, previous pancreatitis. You really can add up to 30% of risk, and the patient is considered high risk if he has at least one definite risk factor or two likely risk factors. This should be discussed with the patient before the procedure. So oral and written informed consents are very important to obtain. And we can see here the increase of the claims, malpractice claims, especially in ERCP, they're going up. So we have ways to prevent, hopefully, ERCP pancreatitis, post-ERCP acute pancreatitis. So NSAIDs, we know that there is an amazing amount of data, ARISTs, and even 28 meta-analysis on rectal NSAIDs. We know that they are very effective, that both diclofenac and indomethacin can be used. Only the intrarectal route is effective, and there's no serious adverse effects related to NSAID use. So it's recommended to be given to all patients before ERCP that have no contraindications. So pregnant women over 30 years of gestation and allergy and no Stevens-Johnson syndrome are excluded. What about IV hydration? This is a new kid of the block, but also considerable amount of data can or reduce post-ERCP acute pancreatitis. Lactate ringer is a preferred solution, but there have been no adverse events in these protocols, but you have to consider the careful patient selection. So it can be considered as a preventive method in patients that have contraindications to NSAIDs, provided that they're not at risk of fluid overload and you have not placed a prophylactic stent. What about stenting? This is also very useful. It's been shown to be efficacious. And especially in the case of a guide wire in the Pancreas situation, we use 5 straight 5-French stents with no internal flange or a single pigtail. We have to do an X-ray and retrieve these stents within 5 to 10 days. So this algorithm shows as well a proposition. First of all, if there's any contraindication to NSAIDs, if no, we'll give rectal NSAIDs. If yes, we will consider hydration. If there's a contraindication to hydration as well, consider sublingual glycerol nitrates. If the procedure is difficult and we can put a pancreatic stent, then we will put a pancreatic stent. If we cannot put a pancreatic stent, then in this case, we will continue hydration. And there's also been the question about how about combining. This is one of the recent studies from the Dutch that put this to the test. They compared aggressive fluid hydration plus NSAIDs versus only NSAIDs. And this showed that there was no benefit from adding hydration. So we still have an unanswered question regarding combining our preventive methods. So to conclude, know your indication, only therapeutic ERCP is accepted. Know your anatomy, position is crucial. Being gentle and touch the papilla as less as possible. Use guide wire initially and add a little contrast according to expertise, always trying to limit pancreatic manipulation. Step-up approach with standard cannulation techniques, expertise, followed by pancreatic guide wire assisted techniques, always with prophylactic pancreatic stenting, and pre-cuts only if expertise and clear therapeutic benefits. And consider post-ERCP acute pancreatitis by identifying risk factors and providing optimal prevention. Thank you very much for your attention, and I'll be glad to answer the questions.